So what I'm going to talk about for the remainder of the morning are some very specific areas, namely hydration and feeding. But I think many of the principles that we'll talk about to make decisions in these specific areas are transferable to other challenging areas of decision-making in end-of-life care. What types of treatment, if any other treatment, is appropriate, the use of palliative sedation, just about any other treatment that we might talk about. And even somebody during the break, we were talking about Reiki in patients at the end of life, and it's appropriate to use appropriate to have the right decisions around whether or not that patient wants to have alternative therapies as well. So without further ado, what I want to do this morning is talk about, I want you to be able to list the factors to be considered when making decisions about hydration and feeding at the end of life. I want to make reference to a decision-making process that we've developed for hydration at the end of life and feeding at the end of life. And by giving you these processes that we've developed, just as I did with the clinical practice guideline for sedation, I'm not suggesting that you necessarily use what we've developed, but these are merely examples and meant to give you just an example of how it can be done. You need to develop things that are right for your particular location of care, whether that's a hospital, home care, or a rural area, because there's going to be different things that you consider because of the kinds of resources, the kinds of patients or clients that you care for. So don't for a minute think that you have to take home what Ted says they're doing in Calgary and transfer it to the areas in which you work. Rather, try to apply it as appropriate to apply the principles as appropriate to your location. Well, you know by now that I like to use patients that I have met to learn from, so let me tell you about the following patients. The first one is a 33-year-old woman in the final stages of breast cancer. Death was expected within a few days. She was unconscious from massive brain metastases, and her mother wanted her to have hydration. The second patient was also 33. He had cancer of the colon with widespread metastases. He was on 600 milligrams of sustained-release morphine per day. He was on a long, slow decline, and we really anticipated, it's kind of unfortunate really, but he was probably going to linger for many weeks. He was quite anorexic and cachexic. He was eating and drinking somewhat, very weak, and he actually was receiving subcutaneous hydration. And his family took us aside one day and said, is this really the right thing to do? Should we discontinue his hydration? And in the third case, a woman in her 70s, I believe, who had had a stroke 6 weeks before. She had a persistent vegetative state. She was totally unaware of what was going on around her. She wasn't responding in any way. And she had had a percutaneous gastrostomy tube placed within the first 10 days after her stroke. And it was still in place 6 weeks later. No one expected that her neurological function would improve in any way. And we were asked to see her because the question had been raised as to whether or not artificial hydration and nutrition was still appropriate. So I'm going to come back to those three cases in a little bit, but let's talk a little bit about how we make decisions first. This is in your handout, and it's really a decision-making framework, ethical decision-making framework that I use conceptually. The actual diagram was developed by Dr. Nathu from the Alberta Provincial Health Ethics Network, so I want to give credit to him. But I think it's what a lot of us follow intuitively when we're trying to make decisions, but he's very nicely outlined it in an algorithmic way. So I think the first question to ask is whether or not our patient that we're trying to help make a decision about health care treatment is to ask whether or not they are competent. And if so, then we simply need to inform them of what their options are and listen to what they say and follow their wishes. However, if they're not, then in Alberta anyway, we're obligated to ask or consider whether or not they have an appointed guardian. And then follow the instructions from the guardian. If they do not, we're obligated to ask whether or not they have an advance directive or personal directive. I believe Saskatchewan has personal directives, am I correct? Yes. I don't know how widely used they are in Saskatchewan. And actually, I don't know how widely they're used in Alberta. Not very common. In the more established jurisdictions where they've had personal directives for many years, about 15% of the population has a personal directive. So still relatively uncommon, but still important to ask. And if they do, then it's important to, of course, follow their instructions and make decisions together with their appointed surrogate decision maker or agent. If they don't have a personal directive, then I think it's important, together with their loved ones, to ask the following questions. And I'm going to ask you to consider asking these 3 questions in the specific order that I give them to you, and I'll tell you why in a moment. I think the first question should always be, in a patient that is not competent, to the loved ones, those people very familiar with the patient, did Mom ever say what she would want in a situation such as this? And it's amazing how often they'll say, you know, Mom said if she ever had a stroke and there was no hope that she'd ever be able to live at home and garden again, for goodness sakes, don't keep me alive, kids. Keep me comfortable and let me go. Well, if you get such a message from the family or people that know the patient, you're ethically obligated to follow what the patient has told you, because that's really what we're trying to do in this whole process, is figure out what the patient would want. If they could come back, what would they tell us they want with respect to their health care? What I want as their physician, what their son and daughter want, their spouse wants, is of lesser importance. The second question then, if you don't get any helpful information from the first, if you get a clear answer from the first, you're done. You deal with that. You make decisions together with the family. You explain to them why you have to listen to the voice of the patient. But if you don't get a clear message, then I think it's important to ask something like, given the way Mom lived her life, given the way she made decisions, given her values and beliefs, what would she say if she could come back right now and help us out? What do you think she would do? And if they kind of, if you're convinced they're sort of considering her values, her beliefs, the way she lived her life, you have to take that as face value and let it guide you in appropriate decisions. If you don't get a helpful answer from those first 2, then you ask the question, what do you think is in the best interest of Mom? And you can see what's happening as you go down this list of 3 questions. First of all, you're getting farther and farther away from what the patient would want. And that's really what we're striving for. What's the second thing that's happening? The answer is that they're guessing or using their intuition as to what the patient would want. Absolutely. And what's likely to influence that? What they want themselves, what their values and what their beliefs are. And I would also say that the other thing that could drive that is guilt. It's really hard to say, I don't think we should continue to give Mom food. There's a sense, no matter how clear I'm given instructions of, I'm pulling the plug. And in fact, the evidence is that no matter how well we do it, those people who make that decision subsequently have that feeling like, I did it. I made that decision. And it shouldn't be their decision. It's the patient's decision, together with healthcare providers. So the risk is that the farther we go down that list of questions, the greater risk they have of feeling guilty afterwards. And guilt and all these other things, their values, their beliefs, driving the decision making. There's a question. Yes. I'm glad that you've mentioned that. I'll just repeat that for the benefit of others in the room. The comment was that often there are unresolved issues or conflicts in the family that provoke the family members to want to prolong things in the hope that they'll be able to resolve those issues and conflicts during that time. And of course, if the conflict is with the patient and they're not going to regain consciousness or competence, the chances of resolving those things are quite unlikely, but it may be a driving force behind what the family says they want to do. Good point. So given those three questions then, we want to try to get an idea of what the patient would want, and then we have to ask the question whether or not the specific treatment that we're talking about will do what we think it's going to do. Is it serving an intended purpose? And if not, and if we're talking about life prolonging measures, we probably should not pursue it. If it is, then we have to ask, is it gravely burdensome without proportional benefit? In other words, is this particular treatment going to be more trouble or more onerous for the patient than the potential benefit? And if no, then go ahead and provide the treatment. So this algorithm, or this decision-making template, I think is helpful sometimes to sort of guide us through this process. Well, let's talk about hydration for a moment specifically. So we've already talked about how there are some ethical issues concerned in making the right decisions about hydration at the end of life. We've talked about the need for informed consent. There are some legal considerations, and I would say there are also some communication issues that need to be attended to. And someone's already mentioned one of the considerations is to address the family's needs through this process. Because all of us are aware that in palliative care we certainly care for the patient, but we want to be supportive and attend to the needs of the family, and that may be part and parcel of the whole process. The communication, the sensitivity, the delivering bad news, and all those other many things that are important to consider in a decision-making process such as hydration at the end of life. But there are also other things. There's some medical stuff. There are some considerations such as what's going on in the pathophysiology of this patient. The 33-year-old with high doses of morphine, for example, was in fact continuing to be hydrated because every time we let his hydration decrease, he developed opioid toxicity and he started to hallucinate and he started to become distressed. And so when we talked with the family and said, we may be prolonging things here, and one option would be to talk to him and stop his hydration and manage his delirium as best we can. We're not sure how that might go, but there's a risk that he may become more distressed because of delirium. And in the end they said, for now let's carry on. And then after a couple of weeks he actually deteriorated further. The decision was made to let his hydration, decrease his hydration, and he died a couple of weeks later. And it was a little tricky managing this delirium, but we got over it. So in that particular case, there were some medical and some pharmacological issues that really drove the need for hydration, and those sometimes are important. There are religious issues, and there are cultural issues that sometimes drive this. How many of you have seen a patient where the patient or family member said, I don't think it's right that we withhold food and water at the end of life. I demand to have an IV. You see that? Many of you are nodding your head. Sure. And it's important to explore those beliefs. Sometimes there are myths that need to be debunked. Sometimes there are genuine beliefs that are driving the process, and you have to understand those and respect those. Sometimes there's just a need to care, and it's really difficult if I'm a family member and I know my loved one is dying and there's nothing I can do about it. I feel the need to do something, to care for them. I've never been through this before. There's no script that anybody has handed to me. And when I was sick, my mother gave me something to eat, something to drink. She cared for me. I've been taught to do that. So there are many drivers socially and psychologically that can drive us in our need to care. And sometimes giving water or food or both is a manifestation of that. Well, we're very quick to recognize all of these factors within patients and families. Let me tell you an interesting anecdote about how I learned about how we all bring our beliefs, cultural, religious, and otherwise, to these decision-making processes. I think it's the third patient, the woman who had had a stroke 6 weeks before, had a peg placed for food, persistent vegetative state, and as a palliative care physician, I was asked to come and see the patient because there were issues about whether or not we should continue to give her food and water. I made an assumption. What I did is I had a family conference, as we often do in palliative care, to try to make a decision together with this family. I had assessed the patient. She was totally unresponsive, unable to participate in this decision at all. The neurologists were convinced that she would never, ever recover neurologically from her state. There was no personal directive or guardian. So I had to help this family through this difficult decision. At least I assumed it was a difficult decision for them. And we had this family conference with her husband, 3 children, a couple of daughter-in-laws, son-in-laws, our social worker, and the family physician. And so I sort of reviewed clinically what the situation was and what our options were in terms of continuing or not continuing. And then I went through my 3 questions. I said, so did Mom ever say what she wanted in a situation like this? And the husband said, well, her brother had a stroke 2 years ago and he was in a coma. And Mary said if she ever was in a state like that, don't ever, ever prolong her life. She didn't want to live dependent on others. She didn't want to live in an institution. If she couldn't appreciate the people around her, interact with them, she didn't want anything to prolong her life. He was just that clear. I thought, this seems pretty clear. I looked to his left around the circle and I thought, there's a minefield here somewhere. Somebody in the family is the problem. So I went to the first son and he said, yeah, Dad's right. Oh, she was very clear about that. And I kind of went around the circle. And they all said the same thing. I thought, well, that's good. I'm going to get lunch today. Then one of the children said, so we talked about, we'll stop the feeding, and one of the children asked, so will she suffer at all? And I went on about how she's in a coma, she's unaware, we don't think that people with terminal illnesses generally suffer from thirst and hunger and so on. And who do you think spoke up? The doctor. And here's what he said. I was totally caught off guard, totally oblivious to this. He said, I disagree. Listen. In his East European accent, he said, my family were in the concentration camps in Poland during the war, and they had food and water kept from them, and they suffered immensely. He was bringing his cultural beliefs, his heritage with him. And I had to respect that. I understood where he was coming from. And in the end, he agreed to disagree, and he agreed to acquiesce to the family's and the patient's wishes. He was very good about it. But it was a real lesson to me on how all of us can do that. This time it was very blatant, all right? But other times we are not so, it isn't so obvious to others or even to ourselves. The beliefs, the assumptions, the values that we bring to a decision-making process. And even though we all sort of guffaw at what this physician said, this was a part of his heritage, his family, his being, that would drive him to make the kinds of decisions at the end of his life. He was telling us about them in the context of another patient, but that's fair. He laid them on the table. I think we need to be careful to acknowledge that in ourselves when we try to assist patients and families to make decisions for themselves, because we will influence them in perhaps inappropriate ways if we're not self-aware of those things, that baggage, if you will, that we bring to the table. So patient, family members, as well as all of us, bring all of these things to the decision-making process. Well, let's talk about hydration then. If there's a controversial area in palliative care, it's probably hydration. And I want to, in the next few slides, just run through some of the arguments that have been used first against hydration, and then some of the arguments that have been raised just as forcefully for hydration at the end of life. Please don't understand that there is evidence for any of the statements that I'm going to tell you about. There is a little bit of evidence for some of them, but most of them, there is very little, if any, evidence. So just because it's black on white doesn't mean that there's evidence for it. But the point I want to make is these are the arguments that come out. First of all, comatose patients do not experience distress. Well, you know, that's probably true. From the evidence we have with people who receive deep anesthesia and so on, they don't appear to suffer physical distress. So it's a bit of an assumption, but probably a reasonable one to make. Parenteral fluids may prolong the dying process. Well, actually the evidence is equivocal. There's only a couple of studies that have attempted to look at this. The methodology behind these studies is problematic and probably will never have an answer here, but it's actually not clear-cut. It's not clear that withdrawing fluid from people hastens their death, or vice versa, providing it prolongs their death. Less urine results in less need to void, decreased incontinence, and the necessity for catheters. Maybe. Don't know. There is less GI fluid and less nausea and vomiting in patients who are not hydrated. I don't know of any evidence to support that. It may or may not be true. There's decreased pulmonary secretions resulting in fewer respiratory tract symptoms in patients who are not hydrated. I don't know. I don't think anybody knows the answer to that. Intuitively, one might think that there's less secretions in a dehydrated patient, but I'm not sure that's necessarily so. Reduced peripheral edema. In fact, that's probably so, and that may be a factor. And I think sometimes when we hydrate, we overhydrate and produce edema, which is uncomfortable. We get skin breakdown, makes it more difficult for the patient to move around, be cared for, and so on. So I think that's something to be considered. Next one is dehydration and electrolyte abnormalities may act as a natural CNS anesthetic, resulting in decreasing level of consciousness and less suffering. I don't know of any evidence to support that. Certainly we know that dehydration and electrolyte abnormalities is a cause for delirium in some patients, and we certainly know that some of these patients are very distressed, as we talked about earlier today. So I have some difficulty with this one. The next one is parenteral hydration is uncomfortable, it limits a patient mobility, and it medicalizes death. Those of you who are new to palliative care, and by that I mean in the last 10 years, may not be aware that up until the mid-90s or even a bit later, the idea of hydration at the end of life was heresy. In fact, I've been at conferences in the mid-90s where there was argument when even anybody suggested the use of hydration at the end of life. Nowadays, in most jurisdictions, it's not uncommon. The question as to whether or not we use it appropriately is still open for debate. But I think the question as to whether or not some patients may benefit from hydration is probably a qualified yes. But the issue is this whole idea of, well, if we give them sub-Q or IV hydration, then we're sort of introducing a little bit of technology and medical treatment, and death is a natural process, and we're interfering with that, and sort of a real philosophical debate about whether or not that's true. Well, on the other hand, people argue just as strongly that there are some cases to be made for hydration. The first one is dying patients are more comfortable when hydrated. A little bit of evidence to say that delirium might be prevented in some of these patients, although the evidence for that isn't even very good. And I don't know of any evidence that says hydrated patients are more comfortable. Second one is there's no evidence that fluids prolong life, and as I said, there isn't any clear evidence on that. Dehydration can cause confusion, restlessness, and neuromuscular irritability, so we should definitely hydrate people at the end of life. Well, yes, it may, but we've all seen many patients who get dehydrated at the end of life and they appear to die quite comfortably. So to hydrate everybody doesn't seem appropriate either. And then oral hydration is given to dying patients complaining of thirst. Parenteral hydration should be given to those unable to drink. So the argument is, just because I'm unable to raise my hand to my mouth, or just because I have some swallowing difficulties, doesn't mean that I shouldn't be offered hydration. And again, it's an argument that's made. I'm not saying I agree with that argument necessarily, but it's something that's put forward. Parenteral hydration is a minimum standard of care, some say. That's the least we can do for the dying. Withholding parenteral fluid from dying patients may result in withholding therapies to other compromised patient groups. So in other words, dying people are disadvantaged, they don't have a voice. Here we are withholding this medical treatment. This is a slippery slope. And dehydration results in reduced glomerular filtration, which results in more rapid accumulation of opioid metabolites, which may lead to delirium, myoclonus, and/or seizures. And that's probably true. The problem is that we don't actually know which patients require hydration to prevent that. Some patients develop opioid toxicity on 30 or 60 milligrams of morphine or its equivalent, while others tolerate 600 milligrams quite well, even with dehydration. We don't understand why that is. So, given all the rhetoric, shall we say, what is the best approach for hydration at the end of life? Well, one thing to think about is that the two opposite ends of the extreme are probably, neither is probably true or appropriate. The first one is that we should give hydration to everyone at the end of life who cannot drink on their own. And that's probably not appropriate. The opposite end is probably also inappropriate, and that is that we should avoid medical interventions such as hydration at the end of life, period. And we would probably subject some people to unnecessary suffering by doing so. The other question to ask is, by giving hydration, am I going to treat some of the symptoms that people may have? Symptoms such as thirst, dry mouth, decreased urine output, and delirium. So I'll ask you, do you think that hydration will help people complaining of a dry mouth at the end of life? How many think yes? And no? Most of you think not. That's my belief as well. I think good mouth care is probably more effective. I think most people in palliative care who have a dry mouth may or may not be dehydrated, but it's usually the medications that we're giving them that's giving them a dry mouth, or their mouth breathers, or both. And neither of those will be helped with hydration. I'm going to suggest to you, and we can certainly have some discussion later on, that it might be helpful to view artificial hydration at the end of life as a therapeutic intervention. And by that I mean that we consider it as a treatment option. So some treatments are appropriate for some patients and some problems, and that same treatment may be inappropriate for other patients in other situations. And so that we go through the same sort of decision making that we go through with patients and families regarding other interventions. So by that I mean we avoid a firm conviction that either providing or withholding fluids is correct, because there's little basis on which to base that, and that we base our decisions together with patients and families on careful assessment with respect to the clinical issues, the sociocultural issues and beliefs, the information that can be provided to patients and families so they can make an informed decision, and then let's base the decision on specific goals. If we're hydrating this person, why are we doing it? What are we going to solve? So there is an algorithm in your handout that guides you through such a process. And again, I'm not going to go through that algorithm specifically, but I would draw your attention to, I think, the first question on the top of it. And the first question is anyone concerned about hydration? Am I right? Is that what it says? Good. Don't have it in front of me. And by that we mean anyone. Patient, family member, anyone on the healthcare team. So the patient may have a concern, my mouth is dry, nurse, can I have an IV please? And then we address that. We may or may not give them hydration, but we address that concern. The doctor may have a concern because they're on high-dose opioids and we're concerned about opioid-induced delirium. So we address that. Everybody makes the decision together. Everybody, the patient, the family, get the information and they make the decision based on that information. And also you notice that if the answer is no, no one's concerned about hydration, we don't visit it. We don't, it's a non-issue. In other words, just as if an appendectomy is not an issue, it's a medical therapy, we don't raise the idea of an appendectomy. If hydration is not an issue, we don't raise the issue with the patient. I talked about, just go back to the 3 cases in hydration for a moment. So I talked about the stroke patient, who we ended up having the meeting with the family and the doctor had the issues. We talked about the young man on high-dose opioids and the decision was made to hydrate for a time. There also was another goal that was identified in addition to avoiding opioid-induced delirium. I think there was a family member who was coming from out of town in 10 days and they wanted to optimize his cognitive function for that visit. And then I think after a couple of weeks, the decision was made that that goal had been accomplished, and all of us decided that rather than risking prolonging his life by hydrating him, that we would stop his hydration and manage his delirium as necessary. And then the first case, anybody? The mom wanted hydration for her comatose daughter. And the outcome there was sitting down with the mother. You can imagine the grief any of us would have over a dying child. And talking to her about her grief, about why she was concerned about hydration. And indeed, the real need for this woman was the need to care for her dying daughter and to grieve over that. And when we were able to give her support, and offer suggestions about other ways in which she could care for her daughter, hydration no longer was an issue. And we offered to provide it. We said, we don't really feel the need to, but if it would make you feel more comfortable. And she, I think, said, you know, could you give it to her for 24 hours? And could I think about it overnight? We said, fine. The following day, it was, I think part of it was also, well, I've tried that and it didn't help. I'm fine with that now. So it was an example of how making a decision with a family member and supporting them around other issues that were driving the need for hydration was helpful. So I just wanted to kind of recap those cases for you. More cases. First case, the question around these three cases is what do they have in common? The first one is Mr. Smith, who has advanced dementia and no longer has the capacity to feed himself. He doesn't even know what to do with food when it's put in his mouth by somebody else. And his family is asking whether or not he should be tube fed. The second case is Mrs. Black, unable to swallow, result of locally invasive head and neck cancer, for which she had had radiation, and unfortunately she had unable to swallow as a result of that. Her life expectancy was otherwise quite some time, and she had been advised by her physician that a feeding tube actually might be beneficial. And the third one was a stroke that left Mr. Braun with a lot of swallowing difficulties, and a gastric tube was suggested as a way to manage this problem. So again, we'll come back to these cases, but the issue, of course, that's in common is that somebody has raised the question as to whether or not a feeding tube would be appropriate. So in Calgary, we decided to look at this problem from a systems perspective because we were aware that we weren't always making these decisions appropriately. And so we asked the question first, how should these decisions be made with respect to long-term feeding tubes? And we decided to go through a process to come to the answer as to how best this should be done. So we developed something we called the Enteral Feeding Decision-Making Project, committee, working group, whatever you want to call it. And I'm just going to summarize a little bit of what we came up with during that project, So the first stage of the project was really to look at, well, how are we doing? What is the perspective of people around the table as to how we're doing with decision-making about tube feeding in the first place? So it was physicians, nurses, dietitians, people from the ALS clinic, people from the stroke ward, 15 or more people around the table. And so here's a summary of the problems that we identified. So there were things like language discrepancies. When we talked about tube feeding, people weren't sure whether it was NG tube feeding or percutaneous gastrostomy tube feeding or jejunostomy tube feeding, and what were the implications for each of those, and did patients and families really identify the differences when we were talking about them? There were issues around, are we supporting life or are we just prolonging death and illness? There were issues about whether this was a medical treatment or whether this was just appropriate support, getting back to some of the arguments we had with hydration. We found a great deal of inconsistency in the kind of information the patients and families were getting and the practice. If you ended up on one ward, you were likely to get a feeding tube. If you had the same problems, you might not get one down the hall or at a different hospital in the system. We found that there was a great deal of discomfort around how these decisions were being made and the assumptions that were used. Who were the people that were unhappy with the decisions and the processes? Family members who were surrogate decision makers, for one thing. And there's good evidence in the literature to support that that's so. And then often people who were otherwise involved, nursing staff, physicians, dietitians, and speech-language pathologists thought we were doing a lousy job when it came to this process. There was a perception that the decisions were often of convenience. Well, this patient needs to go to a care center. It's going to be easier to feed them with a tube than somebody sitting and feeding them 3 times a day, so let's slip a tube in. Not a good reason to make a decision. Decisions were often made in isolation and often under pressure. So we would give a patient or a family member information and simply sit there in front of them and say, so what do you want to do? Do you want it or not? I mean, obviously delivered in a sensitive way, but a decision like this probably deserves a little bit more time to consider the implications and come back with questions and so on. Then we talked about what the best process and what the best decisions would look like, and we really came up with the following. And I think this is applicable, and I guess if there was one slide you were to take home today, this would be one that I would propose to you. And I think this is true for every decision that we make together with patients and families in healthcare. There are 3 different areas to consider. And I think sometimes we tend to think, you know, when we talk about decision making, we tend to think about things from an informed consent perspective, or from an ethical perspective. Or as a doctor, we think about, well, what's medically the best thing to do? And in truth, we need to consider all 3 areas. We need to consider the clinical information. What are the patient's specific clinical problems? What is the evidence that a feeding tube used long term will address that problem? Will it, or won't it, or do we not know? The second category are the values, beliefs, and attitudes, particularly of the patients and family, but all of us, as I said before. But are there ethnocultural and religious considerations here that we need to identify? If we don't identify them, they're going to be at work, at play anyway. Are there ethical and legal considerations? There still are people out there that think that as a healthcare provider, it's illegal and unethical not to feed someone at the end of life. And we need to be person-specific about values and beliefs. And then finally, I would argue that the third piece we tend to overlook the most, and that's the process. Now, it doesn't always have to be an algorithm or a formal process, but we need to pay attention to the process. I often use a family conference. I get the people on the healthcare team together who I think can give information about the person's clinical information. They may have observed the patient as a nurse. They may have assessed the patient as a speech-language pathologist or a nutrition. And a medical person who knows the medical problems, together with the family and patient, so that we can make a decision together. And timeliness is important. Most of the time when it comes to a feeding tube, there's no urgency. There's time to consider things and do things appropriately. So I would submit these 3 things are important to consider with feeding, with hydration, or any other decision that we make together with patients and families. So the next thing we did after we identified what the problems were is we went to the literature to try to find out what there was in the literature to guide us into developing what would be the best practice when it came to decisions about feeding tubes. And we looked in 5 different areas. We looked at the literature about enteral feeding tubes themselves, what they can and can't do for our patients. We looked at the decision-making processes about how they're made. We looked at ethical principles. We looked at ethical decision-making frameworks that were out there. And we looked at the use of artificial feeding and fluids in different disease-specific situations. And in about 5 slides, I'm going to summarize all of that. And I neglected to mention at the outset, I think her name was on the first slide, I owe a great deal of credit to a woman by the name of Cheryl Knight, who's a clinical nurse specialist in Calgary, who's done a tremendous amount of work to help me with this project, and particularly the literature piece. She did a beautiful job of synthesizing it. Well, when we looked in the literature about enteral feeding tubes, it's just not straightforward at all. It's not very simple. Here's what we found. We found that life prolonging and quality is debated when it comes to end-stage dementia. In other words, it's not clear-cut as to whether or not this helps. There's no evidence that it definitely helps in terms of length of life or quality of life in patients with dementia, but there's no clear-cut evidence that it does not. So that was one of the first things we found. Second was, that contrary to what a lot of clinicians believe, an enteral feeding tube, even a percutaneous one, does not prevent aspiration. So it's in most cases not a reason to put a percutaneous tube in. It does not prevent gastroesophageal reflux and aspiration. The third thing was that enteral feeding tubes can contribute to discomfort and sometimes a need for restraint, particularly in those people with dementia. So they tend to pull at it, and once they pulled it out once or twice, then naturally people are have a tendency to try to restrain them in one way or another. The next thing was at the end of life, the need for fluid and food diminishes, and so the question as to whether or not withholding would cause any discomfort, and it probably does not. Probably most of us in palliative care would agree with that. And interestingly, for most disease conditions, a feeding tube doesn't actually change their nutritional status. So if you look objectively in terms of their fat and muscle and various other parameters that nutritionists look at, it's not terribly convincing for the kinds of patients we consider at the end of life as a benefit. So we then looked at how decisions are made, and definitely the evidence is, as I've indicated to you and all of you would know from your personal experiences, that the decision context is often complex. Often there are multiple issues. Sometimes they're medical, sometimes they're psychosocial or cultural. Sometimes it's the system that's driving the process. And often people are making it under duress. Decisions are more likely to be made in acute care centers in Canada, and in the States it's usually in long-term care facilities. And I understand the biggest driver in care facilities is actually a human resource issue. You put the tube feed in so that it's easier to feed them. You don't need someone there to assist. Is that true in Saskatchewan? Would most decisions around this issue be made in hospitals for feeding tubes? Care centers? No? Next thing we found out is that in Canada, usually it's a neurological event that sparks the issue, so it's a stroke, most commonly, whereas in the States, dementia drives the process, and they have a lot of people with dementia on feeding tubes. And most often, physicians, rightly or wrongly, initiate the discussions. Treatment expectations do not always match reality. In other words, we say, you've got aspiration, this tube will help you, and I've just told you that probably is not true. And we often don't do a very good job of telling family members and patients about the burdens. Cost in some cases, hassle, and so on. We often are very fuzzy about the prognosis when we discuss this with patients and families. We often find that there's evidence to suggest that there's quite a difference in perspectives between family and physicians and nurses. And as I mentioned before, everyone seems unhappy with the process, and the literature bears that out as well. We also talked about ethical issues, or looked into the literature into ethical issues. And of course there's the usual 4 ethical principles of autonomy, beneficence, non-maleficence, and justice. Other considerations that we found were, as we mentioned earlier with decision making, consideration of everyone involved with respect to their values, their goals, legal considerations, the timing of the decision making, and I think most importantly, the assurance that if we don't do this, we're still going to care for you or for your dad. And I think often that we don't give people a choice. We say, we'd like to talk to you about a feeding tube. And we tell them the pros and cons of a feeding tube, but we don't say what we'll do for them if we don't give them a feeding tube. And in some cases that might be, we'll continue to assist them to eat as much as they're comfortable eating. Or we could give parenteral hydration, and we can talk about that. Or we're going to give good palliative care. We're going to keep them comfortable, we're going to support them, we're going to support you, and make sure that we understand that because they choose not to have a feeding tube doesn't mean that we're going to abandon them or discontinue care. And one of the things that was emphasized is the need fairly early on in a process to assess the medical benefit, and in fact, clearly be able to assess and identify whether or not artificial feeding would be helpful, of benefit to the patient. Certainly need to incorporate into a process a recognition and respect for the personal choice, all the things that we talk about with respect to informed decision making, balancing the benefits and the burdens for the patients and their families, and as I mentioned, the consideration of alternatives within the full context of the patient's situation. So then we looked at specific disease conditions with respect to enteral feeding tube. And as most of you are probably aware, in those people with a terminal illness at the end of their life, there's very good evidence in most cases that there's no benefit to artificial feeding. The other thing that was identified, and most of us are aware of this, that there's no ethical distinction between withholding or withdrawing treatment. So in other words, if a person is receiving tube feeding, so the decision has been made hopefully appropriately, the decision to discontinue that or withdraw that treatment is basically similar to the decision that was made, or the process that was made initially to initiate it. One of the problems, of course, is even though ethically it might be the same, it's sometimes more difficult for we as healthcare providers and family to make that decision. So I think acknowledging that is important. And there are some religions that have an imperative continue food and fluid at the end of life, although there's even some debate about that when you look at it in the literature as to whether or not that's true. Those patients with cancer and an anorexic cachexia syndrome, no benefit. Those patients in a vegetative state, there's some discussion in the literature between persistent, which is up to 6 months, and permanent, which is greater than 6 months. The evidence shows that basically you may continue their function physiologically, but as you might have guessed, doesn't really do anything with respect to their cognitive function. And certainly quality of life there's no clear-cut benefit. With respect to neurological disease, other neurological disease, perhaps short-term medical benefit while the individual is stabilized. So we'd sometimes see that in people with strokes, while we're waiting to see whether or not there's any recovery by the brain. And other neurological illnesses would be similarly considered. Probably appropriate in those patients with difficulty swallowing with non-progressive diseases. So our patient with a patient that develops an obstruction in the head and neck, for example, and is otherwise well, might be reasonable to give them tube feeding. Considered appropriate for debilitated but physically stable, mentally competent individuals. Consideration of both benefit and burden, of course. Again, emphasizing that it doesn't prevent aspiration, can increase the burden, as I've mentioned, and certainly requires careful discussion and consideration of quality of life. Dementia was an interesting one, and as I said, in the States it's used quite frequently, in Canada not so often. Definitely literature leaning towards alternative methods of feeding. When you consider benefit and burden, probably falls on the side of being more burden than benefit for patients with dementia. Although it's certainly hard to substantiate that argument very firmly. The important thing, I think, as with many situations with considering it enteral feeding, is to identify when it needs to be reassessed and at what points you might stop it, and identify that with everyone at the outset. Locally invasive head and neck cancer, perhaps appropriate if their swallowing difficulty is, did we go over this one? It's remarkably similar to the last one. Anyway, I think we've talked about head and neck cancers or other head and neck causes for obstruction. And certainly with head and neck cancer, at the end of their disease process, probably not appropriate. So we had gone to the literature and gathered all this evidence. Where did that leave us in our efforts to develop, to answer this question, how should decisions around the use of long-term enteral feeding tubes be made? Well, the answer is the following. We thought that one should first answer the question as to whether or not this was a medically appropriate procedure and intervention. We should talk about the perceptions of benefit and burden on quality of life, and that discussion should be everybody, healthcare professionals as well as patients and families, and certainly be respectful of that unique constellation of problems and issues that patients come with. The guidelines, the guiding principles that we developed were that the person's best interest was the ultimate outcome we were seeking, that long-term enteral feeding tubes are a medical treatment, that the decision-making process is deliberate, set in ethical principles based on valid data of benefits and burdens examined within the context of that individual, and that patients and families should be given accurate information regarding those benefits and burdens. The process we suggested was as follows, and we started off, this is a little bit controversial, we think. We started off by saying it should be the physician that leads the process, and it should be a team process. And the reason we said that was the first question that really needs to be answered is a medical one. Is this really an issue? Is this really an option? And if it's not, then the decision-making process probably changes at the outset. The process should be based on information collected about the individual by all of the healthcare team. Decisions regarding the treatment contribution should be based on the following. If the perception was that the treatment was likely to be beneficial, it should be offered. If the benefits were unclear, then it should be discussed with the patient and family, but a trial period would be offered. And then finally, if it was not deemed to be beneficial, that long-term feeding would not be offered to the patient. There needed to be discussion with the individual about this medical decision, discussion about the benefits and burden, and then we developed, or we decided to use a decision-making tool, which has actually been developed in Ottawa to help family members in particular work through this. We suggested the use of an ethical consultation if those people, if they had access to it, and then a plan for review should enteral feeding be put into place. So, to get down to the punch here, there are 3 different categories then. The first one are those patients who are likely to benefit from a feeding tube. So those are patients who might have swallowing difficulties within the context of a non-progressive or slowly progressive disease, but had good quality of life. Or those people who were nutritionally compromised without swallowing difficulties. And that might actually be a patient with inflammatory bowel disease, for example, who just needed some nutritional supplementation. And for such patients, we suggested that we would recommend the use of a feeding tube and that adequate support and education regarding enteral tube feeding be offered. The second category was those patients which the benefit was unclear. So these are patients who have swallowing difficulties but significant comorbidities and their quality of life has been impacted, and usually related to a progressive disease, dementia or cancer, for example, or those who had persistent vegetative state beyond 12 months. These people should likely have a discussion regarding the benefits or lack thereof for the individual, and it really should be non-directive. In other words, we're not going to offer it, we're not going to recommend it, but it would be offered if they wish to, and with a specific recommendation that it be a trial period of 4 to 6 weeks, after which the family, the patient, and the healthcare team could assess whether or not the patient's goals have been met. And then finally, those patients for which it would be unlikely to be a benefit, those who are in a persistent vegetative state, advanced terminal illness, and/or anorexic cachexia syndrome, it would not be recommended, and important to offer them appropriate palliative care and support in that context. So again, we really really capitalized on those three areas that I talked to you about, the clinical information about that particular patient, considering the values and beliefs and appropriate ethical issues that need to be taken into consideration, and then finally the decision-making process itself. Who should be at the table, at what point, and what information needs to be put into the hands of those people sitting around the table and making that decision. So, getting back to our three cases. Mr. Smith, advanced dementia, no longer with the cognitive capacity to do anything with food in his mouth. And his family is asking, what about tube feeding? Is he likely to benefit? No. Is the benefit or lack thereof clear or unclear? You're saying, judging by you're saying it clearly he won't benefit? All right. So in that case, he would not be offered tube feeding. I can't remember what I put for this one. Unlikely to benefit, so we would not recommend. I would agree. Second one was following a stroke. Mr. Braun experiences swallowing difficulties. A gastric tube is suggested to manage this recurrent problem. Likely to benefit? Benefits unclear? Benefits unclear? Okay. Probably need a little bit more information about this patient to even say so. Sorry?
About his stroke.
Yes, more information about his stroke and comorbidities as well. Sure. But I would agree, either unclear or so I would probably offer it and then reassess within a certain number of weeks. And the last case. Mr. Black, unable to swallow, locally invasive head and neck cancer, otherwise good quality of life, and she's been advised that a PEG might be beneficial. Yeah. Probably. We again, probably need a little bit more information. Head and neck cancer, often they do not have anorexia-cachexia syndrome to a significant extent. So she might be one of these people who might well benefit from an enteral feeding tube, even though she may ultimately succumb to her disease. Very good. So take-home messages then. Decisions about long-term enteral feeding tubes are indeed complicated. They require time and discussion. They don't have to happen in a hurry. They should be bound by ethical principles. And decisions around long-term enteral feeding tubes are first medical decisions and then decisions involving personal choice. And just those three different categories that I emphasized earlier. Tell me about experiences or challenges that you've had in hydration and feeding at the end of life. Wow, that's quite a story. I'm just going to try to summarize that for some of you that may not have heard that. So the story was that of, I think, a relatively young, educated woman who was dying of a terminal illness, and had made it very clear that she did not want any life-prolonging therapies, including hydration, at the end of her life. Had intractable pain, and had refused medication for that as well. Is that correct? So accepted analgesia, but would not accept any extra hydration. And so she had made her wishes against hydration very clear. Her family then came into the scene and were opposed to this and insisted that she be hydrated. And the physician also felt very strongly that she be hydrated. And it was to the extent that there were challenges actually maintaining an IV, technically, and they had to struggle with that as a nursing staff, and then also struggle with administering a physician-ordered therapy, that is IV therapy, against the wishes of the patient. And so you can imagine the tensions within the nursing staff to do that. I can only imagine. Well, there's some theoretical ways of dealing with that situation, and maybe we can talk about that, but then maybe more importantly talk about some practical ways, and I'll talk about the theoretical ways because that's the easy part. And there might be some wisdom in this room about the practical ways of dealing with this situation, Because that's an extreme example, but it's not uncommon in healthcare today. That is when the patient's wishes are very clear, and there's either family or healthcare professionals that are contrary to that, and it creates tensions. What I like to do for myself, and sometimes I'll actually, when I'm asked to come into a situation like this, I'll ask the different people, the healthcare professionals anyway, to look at it from an ethical perspective. Because everybody is doing what they feel is right. And what's driving the nursing staff in this instance to not administer hydration is one of the ethical principles, which is patient autonomy, what the patient wants, absolutely. The physician's need to give IV hydration may or may not be misguided, but often there's an ethical principle that's driving the physician in this case too, and that's which two? Non-maleficence and beneficence. So perhaps the understanding, right, or misunderstanding that the hydration may be a benefit, and perhaps the misguided understanding that ongoing hydration was necessary to not do harm. And the family may have had the same sort of ethical beliefs that this is the least we can do for our loved one, we need to hydrate her. So sometimes when there's a conflict like that, there's a conflict between driving ethical principles, and to identify them can be very important. But of course, in this kind of situation, there are other issues as well. Family conflict, you mentioned, and I gathered conflict around other things, not just hydration. So to try to identify those things and give them support, and in some cases try to work through them. In other cases, you can't work through lifelong conflicts within families. But I think what it comes down to then is you have to come back to what the patient wants. And if there were clear, unequivocal directives from the patient not being made under duress that she did not want hydration, there's an ethical imperative for all of us to follow that, family, physician, and others. So the question is that sometimes people are told that artificial nutrition at the end of life feeds the cancer, feeds the tumor. And I have heard that explanation used, and it's probably counter to our understanding of tumor biology today. The understanding is that with most cancers, not all, but with most cancers, the tumor itself and our immune response to that cancer provoke some biochemical changes in our body that make nutrition unbeneficial or not beneficial. The first thing that happens is many tumors themselves produce chemicals, factors that are released into the bloodstream and will interfere with our appetite, interfere with our liver's ability to adequately utilize nutrition. So we get what's called a catabolic state, a state in which we're breaking down nutritional substances despite the fact that we're basically starving, the person is basically starving to death. The second part of that is that our immune systems betray us in responding to the tumor. I always use the analogy, it's the same as when we get sick with a virus. We tend to lose our appetite and we don't use nutrition very well. Well, our immune systems are basically doing the same thing in the presence of many cancers. They are basically turning off our ability to have a normal appetite and normal intake, and in some cases our ability to utilize food. I don't think there's any evidence that increased nutrition increases tumor growth itself. A patient with Lou Gehrig's disease or ALS, and whether or not they would benefit from a feeding tube. Perhaps. The benefit is unclear. It depends upon the specific patient. Many patients have some patients have mostly bulbar disease. So in other words, they are actually up and around, walking, respiratory function is reasonably well preserved, but their ability to talk and swallow is dramatically decreased. So they can't eat normally. They can use the nutrition if it's put in their bodies, and their quality of life is still reasonably good. So those patients should probably be offered a feeding tube. If, on the other hand, they have dramatically reduced respiratory function, actually, if you've waited that long, then the very act of putting in the tube puts them at risk. And many times we will not offer it under those circumstances. So the answer is some patients sometimes definitely benefit. I think that's so true. So if I can try to paraphrase, and it's a very good question, the challenge is that when we try to give informed consent, for example, at the outset of a new diagnosis of a terminal illness, cancer for example, and the patient says, I don't want any treatment. Is that the scenario? And then something happens that renders the patient incapable of any longer speaking for him or herself. And the family or nursing staff or other people involved in the care of the patient come to the physician or might appropriately come to the physician and say, you know, in the process of her making that comment that she didn't want any treatment, she never dreamed of this kind of scenario. I mean, she never dreamed that she might get simple, uncomplicated pneumonia for which an antibiotic might put her back on her feet for another 6 months. That wasn't what she was talking about. She was talking about her cancer killing her. And I think your comment is a very good one. And I guess my response would be it speaks to the need that we need to be very careful when we get consent from patients. And it's probably more important to get the spirit of what their goals and what their wishes are than the specific treatments that they do or do not wish. And it's one of the challenges that I have with personal directives is they say, I do not want artificial feeding. I do not want life support systems. And I'll tell you a quick anecdote in a minute about that. It would be much more useful to speak to the agent who had the conversation, hopefully, with that comatose person who said, you know, Mom wasn't thinking about this. She was thinking about a feeding tube for 6 months in an institution she would never wake up. You know, an IV for 3 days with some antibiotics and then a 75% chance of going home again, she'd be thinking about something totally different. So I think the concept is one of ongoing informed consent as opposed to just consent at the outset. And I think we need to consider that carefully and not sort of take one conversation or one consent process as the end. It's an ongoing process throughout. A quick example of that. A 35-year-old woman comes into a tertiary care center with acute meningococcemia. It's a bacterial infection in the blood that will kill you within hours if you don't get an antibiotic. If you get IV antibiotics, you have an 80% chance of surviving. He comes with a personal directive that says, I never want to go to the intensive care unit. What do? What did happen was the ICU physician stepped over the line, administered the IV antibiotics, saved this guy's life. 6 weeks later, before the guy was about to go home, he had lost one toe and maybe 2 toes. Otherwise, he was completely healthy. And the ICU physician said, did I do the right thing? And the guy said, I had no idea what I was doing when I signed that. I had no idea of the implications. I just didn't understand that this was the kind of thing I was talking about. So it was a real flag about the dangers of personal directives. I have a commitment to stay on time, and it's 15 seconds after the hour. You've been most attentive. Very much appreciate your participation. Enjoy the rest of the conference.